Our topic for today in the mentor rotation is the formulations. So formulations of buprenorphine. So our objectives are just to list the available buprenorphine products, discuss some of the administration differences between those formulations, and then compare some of the pharmacokinetic parameters, because that's where some of those differences do lie. So for the buprenorphine preparations, we've got two groupings of them, the buprenorphine only. When you look up buprenorphine in a tertiary reference, so something like Lexicomp, Micromedics, UpToDate, it'll list all of the buprenorphine products. There are a handful, so the few at the top are the ones that have approval for treatment of opioid dependence. Some of the ones here that are listed at the bottom carry the indication for treatment of chronic pain, but they'll all be grouped in together. So we have, for buprenorphine only products, the implant, the sublingual tablet, and our long-acting injection. The rest are our buprenorphine naloxone preparations. So we have buccal and sublingual films, sublingual tablets, at the various different available doses that are there. Computer, like my screen just flashed here. So as you can see with them, we don't have the traditional oral preparations for buprenorphine. So there are a couple differences just to keep in mind from an administration standpoint. Starting with the implant. So the implant is a set of 4 rods. It can be used for treatment of patients who've been maintained on some type of sublingual buccal products ahead of time. Transmucosal products is the word I was looking for. But they have to have been maintained on 8 milligrams or less. So the concentrations that are going to be delivered through the implant rods are relatively lower serum concentrations. So if patients do need higher doses, then this may not deliver quite enough of the buprenorphine to control patients. So if they've been controlled on 8 milligrams a day or less for 3 months or longer, then they would be a candidate for the implant. So the 4 rods are surgically implanted into the upper arm. You can see the picture there at the bottom. They open in a fan distribution toward the shoulder. These rods start immediately delivering medication, and they'll deliver medication up through 6 months. So starting at that 6-month time frame, the concentrations will begin to diminish. So there may still be a little bit of medication left in the rods, but not enough to really maintain them long term. So then the decision will need to be made, is another implant appropriate, or should the patient change to a different formulation? For our buccal administration, so our buccal film, those buccal films are bilayer films. They'll have a backing layer, and then they have a microadhesive layer. So the microadhesive layer is going to be the layer that actually attaches to the cheek. The backing layer won't deliver medication backwards, so that way the medication isn't getting put directly into the oral cavity. Buprenorphine isn't well absorbed orally, so if they do get it in their mouth and swallow it, chances are that they're not actually going to get as much of that medication, so that's why that's there. It's going to adhere to the oral mucosa. It takes just a couple seconds, so getting it in place and holding it there, and then it will completely dissolve within 15 to 30 minutes. Because it's on the side and there is that backing, there's not as many reports of taste issues as there are with some of our sublingual products, because most of it does get delivered right through the buccal tissue. Because it is going to be just inside their mouth for that 15 to 30 minutes, it would be better if they don't. They're not talking, they're not eating. We really don't want anything that's going to disrupt the adhesion there, letting it just completely absolve, as opposed to accidentally bumping it off with their teeth, with their tongue, if they're doing something else. This does have relatively rapid absorption, and it can bypass the first pass effect, so it's able to get more of the buprenorphine right into the systemic circulation. Just a couple instructions, things to keep in mind that are a little bit unique if patients are using the buccal films. They shouldn't chew or swallow them. They're not going to absorb very much of it if they do it that way. If they do have an open spot on the inside of their mouth, it'd be best not to put the film there. Wash and dry their hands, making sure their hands are dry. If their hands or fingers are wet, the film can stick to it and may make it difficult to actually get it into their mouth, and it may start to break down right in their hands. So this is likely one of the main ways that patients are taking their buprenorphine, and it's the sublingual administration. So underneath their tongue, whether it's with the film or with the tablets. So it is recommended that patients use no more than 2 films or 2 tablets at one time to ensure that we can get complete absorption. So if when the tongue comes up, you can see that there's 2 sides. They can put 1 film or 1 tablet on each side to then potentially break down. If they do require more than that, it's recommended let those 2 be completely absorbed and then add whatever additional films or tablets they do need. It does take some time. The film breaks down relatively quickly. The tablets may take upwards of a half an hour in some cases to break down. And patients occasionally will report sometimes a grainy texture. So some of the filler ingredients that are used in those tablets are left over. And that's really the sandy, gritty feeling that they may experience, which may be a little bit uncomfortable. So again, even I would say more important than with the buccal administration, no food or drink. It's going to be right underneath the tongue. It would be very easy to dislodge and accidentally swallow. And letting patients know the reason why that's so important is the bioavailability. The amount of medication you're going to get from those tablets or films will be decreased by 1/3 to 1/2. So really significant decrease that they're very likely to notice. Similar to the buccal film, they're placed under the tongue. Clean, dry hands, again, if they are wet, especially with the film, that could start to break down and dissolve right on the fingertips, and that could be really difficult because then they may not get the full dose. So tablets underneath, films underneath, encouraging them not to chew on those. So even if they're in their mouth, trying to keep them right where they're supposed to be. And also really trying not to move their tongue around a lot because that'll create more saliva and then they'll swallow that. If the buprenorphine's in that saliva, then that again may be something that they're not absorbing ideally. The newest formulation that had come out, which isn't necessarily new anymore, but is the subcutaneous injection. So this is an opportunity for patients. It does not have the restriction like the implants had on needing to be maintained on 8 milligrams or less for 3 months or longer. These patients just need to be on transmucosal, so either films or sublingual tablets for at least a week. So ensuring that we can see that the patient is doing relatively well on this, they can tolerate it, it's helping with their symptoms. It's a gel, so when it's injected subcutaneously, and when the gel's injected, it actually becomes a deposit. So it solidifies a little bit and then slowly breaks down and releases buprenorphine over time. It's recommended that the administration site be rotated. So as you can see in the picture, at least those 4. There have been a number of reports where that deposit, even from the first injection, may still stick around. There may not be any buprenorphine left to be released, but they may still be able to feel that hard deposit, and it may take some time for some patients to fully break that down. It's recommended that these are administered in the abdominal subcutaneous tissue. It's 300 milligrams monthly for the first couple months and 100 milligrams monthly thereafter. So recognizing that we've got some options, how do they differ? What are the differences that we see between these agents? So for the buprenorphine implant, even though there are rods that need to be surgically implanted, they start to release right away. So once they're in place, they will release medication. So we see peak concentrations at 12 hours. So within that first day after they're placed, they can see pretty significant plasma concentrations. They reach full steady state at 28 days. And then those concentrations are maintained for the remaining 20 weeks. So they really will have adequate coverage for that full 6-month window. But that adequate coverage, again, really is equivalent to about 8 milligrams of a sublingual tablet daily. So if patients were requiring more, they may not be ideal candidates for this. And coverage, from a finance perspective, also does tend to be a little bit tricky for this one. In looking at the transmucosal products, we do have a couple differences between them. So the buccal film has much better bioavailability than what we have with the sublingual film or the sublingual tablets. So the bioavailability is about 65% with the buccal film. Likely it's because of that backing. So we're getting the medication that's delivered directly into the buccal tissue. It's about 30% for the sublingual film, likely because that dissolves relatively quickly, and it's about 15% for the sublingual tablets. There is a difference between the tablets that we'll talk about in just a little bit, but it does take some additional time, and with the tablets just underneath the tongue, there may be just a reaction to swallow. When I started doing this presentation, I don't know if I should admit this or not, I was thinking, okay, so if this is something that you needed to do every day, I'm one of those people, I'm not gonna finish one of the Tootsie Pops, I'm not licking it all the way to the bottom. We're gonna get a little ways in and then I'm crunching that off. Same with Tic Tacs. Tic Tacs or mints, they don't stick around until they're all the way gone. I usually end up chewing them up. So it may be that they unintentionally do that sometimes, and that could be a really hard habit to break. Because I've been testing myself, I've gotten better, but that could be really problematic for the patient. So recognizing that if we switch between products, there may be a pretty big difference that patients see just because they actually are able to absorb more of the medication from the formulation. Excuse me. The time to peak concentration, so how quickly does the medication get in there? Pretty quick for all of them. Within an hour to 2 hours, they're reaching their peak concentration. So it doesn't take much time for them to start to feel that effect. And then the half-life for these products is right around a day, maybe slightly less for the buccal film. Now, one of the things that means is it will take about 5 days. So 5 half-lives, 5 days, if we're making a change, if we're starting things until they really get to steady state. To see how well this may work, to see how well they may tolerate these new doses, if it's going in either direction, up or down. So slight differences. When we look specifically at the different preparations compared to each other, this came from the package inserts. The sublingual film definitely has a number of times that it's reported to have higher concentrations than our sublingual tablet, likely because of that bioavailability. So you see that there may be much higher concentrations achieved with the film. Buccal film, it's across the board, has higher concentrations achieved than the sublingual tablet, which again, with that bioavailability, no big surprise. When we look at the films compared to each other, it does appear that the buccal film does achieve higher concentrations than what we see with the sublingual film. So between the three, we'd be able to get highest concentrations with the buccal film, then with the sublingual film, then with the sublingual tablets. So if there's an ability to change between formulations, if a patient really is struggling and needs a little bit of a higher concentration, that might be an option, although sometimes formulary restrictions make that really difficult to be able to do. Because there are those differences, there is a recommended dose change. It's not a one-to-one dose. So you see the sublingual tablet dose compared to the buccal film dose is almost cut in half. So because they are able to get so much more absorbed from that formulation, they really don't need as high of a dose each time. So it's not that somebody had a dramatic dose cut, they're getting the same concentrations, it's just delivered in that little bit more efficient manner. And as I had mentioned before, we do have a little bit of a difference with some of the sublingual tablets. So specifically with the Zubsolv tablet, it's prepared in a different way than some of the other sublingual tablets. So by dry mixing and direct compression. So those sublingual tablets tend to be lighter, and they have a higher bioavailability. So they're able to dissolve and deliver the buprenorphine a little bit more efficiently than some of the other buprenorphine products. So because of that, they actually are able to use lower doses of the Zubsolv and achieve the same concentrations. So the 5.7, 1.4 is equivalent to the 8/2 of the Suboxone, and they'll receive, the patient will achieve the same concentrations in the body. The other thing that could be a big advantage is the dissolution time. So on average, Zubsolv can dissolve within 5 minutes and Suboxone takes about 12 and a half. Although in some cases, the upper end could be in the upper 20s of minutes to get some of those tablets to dissolve. So last formulation is our subcutaneous injection. So this is the deposit that gets injected. To think about how much medication is being delivered to these patients. So the first 2 columns are buprenorphine. So that's given 12 milligrams daily or 24 milligrams daily, and patients have been on it for at least a week. And then for the injection, so that 300 milligram first injection, what the concentrations are, and then patients who are receiving either 100 milligrams or 300 milligrams monthly. And what you'll see is with all of those injections, they're achieving concentrations that are the same, if not a little bit higher than what patients would achieve with the 12 milligrams of buprenorphine daily. So they would be able to maintain a patient who may need some of those higher transmucosal doses and be able to have those same concentrations for them throughout the month. For the 300 milligram monthly, the concentrations that they're achieving are also over the 24 milligrams daily. So for patients who are using higher concentrations and still aren't quite having all of their symptoms controlled, that might potentially be an option. And that is it for the formulations.
Thank you so much, Dr. Dugan. I appreciate that. We didn't do our introductions or anything yet, so we'll hold that for a minute. But does anybody have any questions, comments, or reactions related to that presentation, that topic? Yeah, Dr. Pab. Oh, we'll go Dr. Pab, then we'll go to Dr. Goldman. Go ahead, Dr. Pab.
Sarah, I find it quite interesting. This is about the third or fourth